Hello everyone and welcome to today's Gene Health webinar. Today's topic is Contraception Update. We are pleased to welcome our presenter for today, Dr. Kathy McNamee, Dr. Susan Pearson and Dr. Janine Manwaring. This webinar is live and interactive. You're encouraged to participate by posing questions to the presenter, which can be typed in the chat box located at the bottom left-hand corner of your screen. If you're experiencing difficulty hearing the sound during the webinar, please dial the 1-800 support number listed in the chat box. I would now like to pass you over to Louise to begin.
Thanks, Carolyn. My name is Louise Brown. I work in the translation and education area of Gene Hales, and tonight, together with Family Planning Victoria, we're really excited to present our first 2016 webinar for health professionals. Firstly, I'd like to start by acknowledging the traditional custodians of the land we're presenting on and the land we're reaching tonight, and pay respects to elders past, present and future. For those of you who don't know, Gene Hales for Women's Health is a national not-for-profit organisation dedicated to improving knowledge of women's health throughout the various stages of their lives and provide a trusted, world-class health service for women. We combine research, clinical care and practical education for women and health professionals. We've had over 800 registrations for tonight's webinar, which is fantastic and a great start to the year for us. And at the moment, I think we've probably got about 200 people online. So just a reminder, as advertised, we're focusing on the use of contraception in women, and we have had some questions submitted regarding contraception in men, but we're not covering that tonight, so just putting that out there right at the beginning. As Carolyn explained, we're going to use the chat box. We are having a little bit of technical issues tonight, so we will try and get to some of your questions, but we have had over 100 questions submitted when people registered. So we've got a lot of questions already. Some of these have been incorporated into the content. But look, just to test out your chat function anyway, type in the chat box on the left-hand side where you are so we can see where everyone's logging in from tonight, just as a little way of introducing yourselves. Also, hopefully people have had a chance to look at the pre-reading that you would have received when you registered. There's some really great articles, so if you haven't had time to have a look, you might find them useful to read afterwards. Under the Resources tab, which you'll see down in the bottom right-hand corner, you'll find the journal articles, the handouts for tonight, some speaker bio information. There's some IUD problems, a summary of IUD problems in clinical practice. There's some contraception resources, and there's a summary sheet from the UK MEC, which Kathy will explain soon. After the webinar closes, the resources won't be available, but they will be available again when the webinar's housed in the Gene Hales library, and we'll send you an email about that probably later in the week. And we ask, if you want to get CPD points for tonight, that you need to complete the evaluation. So you'll be taken there straight, once the webinar closes, you'll be taken to the evaluation. So if you want to give us some feedback or if you want the CPD points, please complete that questionnaire. So tonight, I'm not going to read the bios of our speakers. You can have a look at those in the resources panel. But as Carolyn has already mentioned, we've got Kathleen McNamee, who's a GP and the Medical Director of Family Planning Victoria. We've got Suzanne Pearson, also from Family Planning Victoria. She's a GP and she's a senior medical educator at Family Planning. And we've got Janine Manwaring, who's a gynaecologist and laparoscopic surgeon. She works at the Gene Hales Medical Centre as well as Mercy and Women's Hospital in Melbourne. So welcome to the panel and thanks for joining us tonight. We've got a little bit of a different format tonight. We've got Kathy and Suzanne will do their key points first. They're each going to do a case study, and then Janine's going to do some specialist topics. And then we'll have some frequently asked questions and hopefully get back to some of your questions as well. Because we're having some technical issues, we actually have only got one hot seat and we're swapping between speakers. So please forgive us when there's a little bit of seat shuffling, but it's so that you get the best experience. So I'm going to now introduce you to Kathy McNamee, who's going to start off the webinar. Thanks.
Thanks, Louise. I'm talking about medical eligibility criteria for contraception. We often refer to them as MEC. Sorry, wrong way. So we actually base our criteria on the UK medical eligibility criteria, which is largely based on the WHO medical criteria. The most recent update was 2009, but if you watch the website below, we're expecting an update. It's actually around about late April 2016, and there will be a few changes available in your kit as part of this, and it's something I use most days. So with the MEC, there are two criteria, initiation and continuation, and where it's not stated whether it's initiation or continuation, it's the same for both. Initiation is if you're starting a method of contraception for a woman with a specific medical condition. And continuation is if she develops the condition for the first time while using the method. So I'll have a few examples of those. So there's 4 MEC levels. MEC 1 is very self-explanatory, no restriction on use. And an example might be an IUD in a woman with a past history of an ectopic pregnancy or a woman who is nulliparous. MEC 2, we generally more or less treat as a MEC 1, but if you've got a number of MEC 2s leading to the same condition, that's where they can be useful. For example, if you've got a young woman who smokes, that's a MEC 2 if she's under 35. If she's got diabetes, that's a MEC 2. She's got a BMI of 33, so that's a MEC 2. So she's got 3 MEC 2s that are increasing her risk of cardiovascular disease. So you'd actually assess that at a higher level. So just a couple of examples would be a progestogen-only method and a past or current VTE. And an example of initiate, a progestogen-only woman, in a woman, initiate a progestogen-only method in a woman with a past history of stroke. Sorry, that should actually be specifically an implant or the progestogen-only pill. Whereas if she actually developed the stroke while she was using the method, it would become MEC 3 to continue because it's thought perhaps the method contributed to the stroke. Another example is if a woman's diagnosed with PID while she's got an IUD in, to continue with the IUD, it's MEC 2, whereas obviously if she had PID, you wouldn't actually insert, so it would be MEC 4 to insert. MEC 3 is the hard one. The risks usually outweigh the advantages, but you have to take into account the risk of the medical condition on pregnancy, and it might require specialist input. An example might be a progestogen-only method in a woman with severe decompensated cirrhosis, or to continue a progestogen-only woman in a woman who develops a stroke while using the method. The MEC 4 is very straightforward. It's an absolute contraindication. An example is someone with current breast cancer and any hormonal method of contraception. So just a couple of common ones, MEC 3 to 4, not an exhaustive list for progestogen-only methods, and this includes the hormonal IUD Mirena. Current breast cancer is MEC 4, severe decompensated cirrhosis is MEC 3, and with DEPO, a past history of ischemic stroke, heart disease, stroke, or TIA. For IUDs, and this includes both the copper and hormonal, a current infection, that's obviously a MEC 4. Most cancers, gynecological cancers, although there are some exceptions, and distortion of the uterine cavity is MEC 3. So something like fibroids per se is fine, but if they distort the uterine cavity, you may not be able to insert the IUD, and it may be more likely to fall out, and you can't guarantee the contraceptive efficacy. The pill has got a whole range of MEC 3s and 4s, and some of them are quite common, like migraine with aura, which is MEC 4 or MEC 3, if you've had none for, that should actually be 5 years, sorry. Smoking in age 35 plus, just depends on how many you smoke, whether it's 3 or 4. BMI greater than 35 is MEC 3. Diabetes and vascular disease is MEC 3 to 4. First degree relative with a VTE at 45 or under is MEC 3, regardless of testing. Past history of VTE or thrombogenic mutation like Latin 5, that's MEC 4. Past history of ischemic stroke, heart disease, TIA is MEC 4. Postpartum less than 3 weeks is MEC 3 to 4, and lactation greater than 6 weeks is MEC 3. Or MEC 2, depending on how much they're breastfeeding. So I'm just going to pass you over to Suzanne Pearson.
Great, thanks very much, Kathy. So I would just like to talk a little bit about LARC. We've got a really strong focus on LARC at the moment because they're very effective contraceptive, and they are the first-line choice for women of all ages. So long-acting reversible contraception refers to contraception that's administered less than monthly. And the LARC methods that we have available in Australia are the hormonal IUD, which lasts for 5 years. We've got the copper IUD, and depending on type, that lasts either 5 or 10 years. We've got the contraceptive implant that lasts for 3 years, and then also the contraceptive depot injection, which lasts for 12 weeks. Now, the depot injection has a more frequent administration and has lower continuation rates, so we consider that to be a second-tier LARC. There are many advantages to LARC. There's a large US study. In fact, just popping up on the screen now, we've got our first poll, so I might just talk about that before we go on to talk about the Choice Project. So the poll that we're asking you today is, which contraception do you think has more women continuing to use it at 12 months of use? And your options are the combined pill, the implant, depot, and IUD. Okay, so we're getting a few answers in. Okay, well, very interesting. So far we seem to be getting most responses for IUD, and then probably second is the combined pill. So, and we'll find out a little bit more about that in a few slides. So I might close that poll. Okay, fantastic. All right. So as I was just referring to, the Contraceptive Choice Project is a project in the US where they recruited almost 10,000 women who were prepared to change to a new reversible method. And the outcome of that project was that women who are using a short-acting method such as the pill had an over 20 times increased risk of unintended pregnancy compared to women who chose a LARC. So that's a really significant difference. Now, LARC methods contain no estrogen and therefore have very few contraindications, and they are a very cost-effective contraceptive method for most women. The graph shown on your screen shows some other results from the Contraceptive Choice Project. It's looking at cumulative failure rate at 1, 2 and 3 years. So if we look at the 3-year failure rate, for the reversible, so for the short-acting methods such as the pill and the ring, there's an almost 10% failure rate by 3 years, which compares quite differently to the LARC, which is in the blue part of the graph, which is only around 1% failure rate at 3 years. Okay. All right, and some more figures from the Contraceptive Choice Project now looking at continuation rates. So this will be interesting to see how this compares to the poll that we've just conducted. So if we look at the blue lines here, you can see that by 3 years, continuation rates for the LARC methods were 67.3%, and that compares to the non-LARC methods at only 30.2%. Interestingly, this also seems to apply for younger women. So women aged 14 to 19 also had much higher continuation rates for LARC compared to the non-LARC methods. Now, I'd suggest that something that's really important to do with women who are seeking contraception or coming back for a repeat contraceptive prescription, it's important to do a brief and proactive approach to discuss LARC with women. So what I would do is I'd explain the methods very briefly, just outline the key points, and then really focus on the key benefits for women for considering LARC. LARC are highly effective, they're very convenient to use, and they're also reversible so that women can have these removed and they are reversible. Now, LARC tend to be very cost effective and many of the LARC methods, excluding the copper IUD, are listed on the PBS. Something that I think is really helpful is to show women a picture or a model of the implant and the IUD so that they can have an idea about the size and the location of those devices. And then also to mention to women, how can she access a LARC insertion? So is that something that she can access through your clinic, or would she need a referral? Can she access that on the day, or will there be a wait for her LARC insertion? Now, Family Planning Alliance Australia have developed some resources to use in clinic, and so I'd like to show those to you now. This is the first one. It's called the Contraceptive Efficacy Card, and this is a card which shows in picture form all of the different contraceptive methods that are available in Australia, and it puts them in an efficacy framework. So we can see that the most effective contraceptive methods on the left are over 99% effective in typical use. So we've got the contraceptive implant and the IUDs there, and also sterilisation methods. Then we have the medium effective contraceptions, which are 91% and above in typical use efficacy, such as the injection, the ring and the pills. And then we have the least effective methods on the right. Now on the back of that card, there's also a resource to help you to show your patients a little bit more about the LARC methods. So it shows the IUD and the implant, it shows the size and also the location that those methods are inserted into. Now another resource, here we go, we've got our second poll, so I'll just read this one out for you. With this poll question, is it your practice to discuss LARC as an option for women presenting for contraception, including repeat pill scripts? So do you do that never, rarely, sometimes, often, or always? Great. So what we're seeing there is that, in fact, most of you are actually having a LARC discussion with your patients at least some of the time, and many of you are doing that often or always. So I think that the message about the importance of LARC is certainly there with you, which is really pleasing. Okay, we might close off that poll now. Okay, and here's our second contraceptive resource for you. This is a guidance to the management of troublesome bleeding with progestogen-only LARC. So initially, it's important to provide a woman with accurate information about the expected bleeding pattern, and also to be proactive about offering management if a woman is experiencing troublesome bleeding. Then on the right-hand side of the card, there's advice about how to actually manage that bleeding. So first of all, to explain the expected bleeding pattern with progestogen-only LARC is at the top of the card. With the implant, we expect about 1/5 of women to experience amenorrhea, and we can reassure women that that's safe. Around 3 out of 5 women, so most women with the implant, will experience infrequent and irregular bleeding, and 1 out of 5 women will experience frequent or prolonged bleeding. And for those women who are experiencing that frequent or prolonged bleeding, about half of those women will improve after around 3 months. The hormonal IUD, we often see spotting, which is quite frequent in the first 3 months. But after that time, generally women experience either amenorrhea or light bleeding. With the depot injection, around half of women experience amenorrhea, a sixth experience infrequent irregular bleeding, but a third experience more frequent or prolonged bleeding. And here's a web link that you can find both of those resources on the Family Planning Victoria website. And I'm going to pass over to Kathy now, who's going to go through our first case study. Thanks, Kathy.
Thanks, Suzanne. So the first case study is Jane. She delivered a healthy baby 7 weeks ago, vaginal delivery, fully breastfeeding. She had sex for the first time 3 days ago, didn't use a condom as she was told breastfeeding was effective. And look, she's probably right, it's about 98% effective, provided the infant's fully breastfed, it's less than 6 months postpartum and periods haven't returned. Oh, sorry, gone backwards. So in terms of Jane's options, I've just gone back to looking at the combined hormonal methods first up, which is the vaginal ring or the combined pill. If the woman's fully breastfeeding, less than 3 weeks, basically less than 3 weeks, it's either MEC4 if she's breastfeeding at all or MEC3 to 4 if she's not breastfeeding. That's been a recent change to the MEC criteria because it's been noted that the high risk of DVT actually continues on well up to 6 weeks postpartum. So it depends on what risk factor she has for DVT. For example, if she had a cesarean, transfusion, immobilised. 3 to 6 weeks, it remains MEC4, no matter how much or little she's breastfeeding, and 2 to 3 if she's not breastfeeding, depending on her risk factors. 6 weeks to 6 months, it's MEC3. It's likely this will change with the new guidelines, but at the moment it's actually MEC3 if she's fully breastfeeding. People are becoming a little bit less conservative about this because there's not really evidence that that estrogen actually affects the breast milk production once lactation is established. But this is what it is at the moment. If it's less than half, it's a MEC2, so on balance okay. Not breastfed is MEC1. Whereas if it's more than 6 months, it's MEC1 no matter how much she's breastfeeding. Just for the other methods, for the progesterone-only pill or implant, you can initiate those methods immediately. It doesn't matter whether the woman's lactating or not. With an IUD, lactation doesn't come into the picture. You can actually have the IUD inserted immediately postpartum. It's not performed so commonly in Australia. There's a reasonably high chance that the IUD will fall out, but at least it's in there in the first place. And, you know, a lot of women don't come back for a checkup post-delivery. However, if you miss that immediate time, you really need to wait till 4 weeks. Once you get to 4 weeks, it's actually MEC1 to insert an IUD. With depot, it's actually MEC2 until 6 weeks, then it becomes MEC1, whereas if they're not lactating, it just remains MEC1. So the final decision is that she decides on a hormonal IUD. One of the difficulties, not for Jane so much because she's fully breastfeeding and you can be reasonably confident that she's got contraception, she's fairly early on, that is how you exclude pregnancy, particularly if you've got a woman, say, who's partially breastfeeding, periods haven't returned, maybe practicing something like withdrawal. And basically our advice is use condoms or abstain for 3 weeks and then a negative urine pregnancy test. It's a bit draconian, but you do really need to be sure with an IUD. So just the information to convey, if someone's having a hormonal IUD, the costs, it's on the PBS, which is great, but there may be insertion costs. What will actually happen on the day? She needs to know that there is nearly always some sort of pain, huge variation in how much. The risks, which include being unable to insert, vasovagal infection, perforation, and the perforation risk is actually increased by about 6 times with lactation. You're still starting from quite a low base, but it is a big increase in the risk. Failure as a method, and with that, the woman you have to have a high index of suspicion of ectopic pregnancy. Failure is quite uncommon, but if it does occur, a high percentage of those pregnancies are actually ectopic and male dyspareunia. We usually say around 10% will need some sort of additional review, like they might need an ultrasound for niggling pain or whatever, and there's about an 80% continuation rate within a year. We ask them to check the threads about once a month, and if there's no thread, they really need to assume that there's no IUD until it's been sorted out and use alternative method of contraception and sometimes emergency contraception if it's appropriate. Usually the IUD is still there, but it really needs to be sorted out first up, whether it's actually fallen out, it's a perforation or the strings have just moved up into the canal. I find hormonal side effects are common during the first few months, but they seem to be quite short-lived, and most women they will settle down with. And unscheduled bleeding is quite common in the first 3 to 6 months, but often if you're lactating, you actually tend to skip that settling in with the bleeding. So I'll just pass over to Suzanne. And message up there about technical support.
Okay. See if I can change slides here. Seem to be a bit stuck. Oh, here we go. Okay, so our next case study is Jessica. Jessica's age 17 and she's been sexually active for 1 year. Jessica's been taking the pill for 2 years and doesn't report any particular problems. She's come in today requesting a repeat script. And you find out that she actually ran out of her pill 2 weeks ago. She found it difficult to get in to see you because of her school exams. So you take a further history and you find out that although she hasn't had any missed pills, she actually has sometimes been late to fill her script at the pharmacy. She's got a past history of heavy menstrual bleeding and dysmenorrhea, and she is worried about gaining weight on the hormones. Her BMI is 24 and she's a non-smoker. Her sexual history reveals that she's had 3 male partners and she's currently in a relationship for 6 months with a male and is not using condoms. You ask about family history and she tells you that her mother, who's aged 42, had a blood clot in her leg last year. And her parents are unaware that she's sexually active, and that's something that she is keen to keep as it is. So I've just highlighted some of the really important parts of the history here. So first of all, Jessica has run out of her pill 2 weeks ago and has had a break. She also tells you that she's late sometimes getting to the chemist, which is putting her at risk of unintended pregnancy that she may not be aware of. She's looking for a contraceptive method to help her with her bleeding, and she also doesn't want something that's going to cause her to put on weight. Jessica's not using condoms, and this is an opportunity to do some STI screening for Jessica. So a first-pass urine chlamydia PCR would be indicated today, and also it's a good opportunity to talk to Jessica about using condoms as well as the hormonal contraception. Now, we've identified that there's a significant family history with venous thromboembolism in her first-degree relative, her mother, so that's something that's going to be important. Lastly, as we've discussed, Jessica's parents are unaware that she's sexually active and she's wanting to keep that the way that it is, so that we need to consider that in any contraceptive choice for Jessica. So an approach to progressing with Jessica, first of all, this is an ideal opportunity to discuss LARC methods, to let Jessica know that they're available and what the benefits are. Remember to just consider emergency contraception for Jessica. So if she has had if she's had unprotected sex in the last 5 days, then it would be a good idea to offer this to her today. Have a think about the MEC classification for all of the options that are available to Jessica. First of all, if she continued to take the pill, she's got a first-degree relative who's experienced a VTE, and that relative is under the age of 45, so that's actually a MEC3. So generally, the risks would outweigh the benefits for Jessica for taking the pill because of the estrogen. The progestogen-only pill is a MEC1, but it's got a very narrow window to remember, and it's not generally a method that would be chosen for a young person. The contraceptive implant is a MEC1, so it's suitable, and the depot injection is a MEC2 because of the concern about bone density, but generally this would be usable. An IUD would be an option for Jessica. Her nulliparity is not a contraindication. Her age being under 20 is a MEC2, and again, these methods would be usable. There are a few specific issues for Jessica that we identified. So first of all, dysmenorrhea. Now we know that that all of the implant, the hormonal IUD and the depot should all improve her period pain, whereas the copper IUD can increase period pain. In terms of the heavy bleeding that she's experienced in the past, the implant, the hormonal IUD and the depot should all decrease bleeding on average compared to the pill. The hormonal IUD will actually reduce bleeding the greatest, whereas the copper IUD can increase bleeding. Jessica was concerned about weight gain, and there's no evidence of weight gain with the implant, hormonal IUD or copper IUD, whereas the depot injection, around 20% of women will gain about 10% of body weight in a year, so that could be a concern for her. In terms of privacy, all of the methods are pretty private, and it's just a matter of discussing the specifics with Jessica. Now, Jessica's 17, and so this consultation involves a mature minor assessment. The exact requirements for this assessment do vary just a little bit depending on which state and territory that you're working in, and I'll refer you to the Australian Family Physician article referenced on the slide here. The legal age of maturity is 18, and there's no assumption that those who are less than 18 can or can't consent. So what we do is that we do a mature minor assessment, which is a competency-based assessment. And we need to decide whether the young person has an understanding of the features, such as the nature, purpose, effect, consequences and side effects of the method. We need to discuss with the young person whether she is able to talk to her parent or guardian about the treatment or whether she's refusing to discuss it with them. We need to make a decision whether it's in their best interest to prescribe this treatment, and then finally to make a judgment whether the young person is mature enough to make a rational judgment. In the notes we'll document our assessment, and that may include a HEADS assessment or similar, and then to document our decision about her request for contraception, whether she's decided that she can tell her parents or not and the reasons for that, and then our assessment that it's in her best interest to prescribe. So Jessica does decide to proceed with the contraceptive implant in this case. So the information that I would provide to Jessica would be, first of all, to let her know when does the method work, and if she has it inserted day 1 to 5 of the cycle, it's effective immediately. If she has it inserted at any other time of the cycle, then it's effective in 7 days. We need to explain to Jessica accurate information about the expected bleeding pattern, and also to let her know that if she does experience difficult bleeding patterns, that there is a good chance that that could improve after 3 months. But also to encourage her to come back so that we can help her with management of troublesome bleeding if need be. There are some possible hormonal side effects which can be experienced initially but are likely to improve. Liver enzyme-inducing medications will interfere with the contraceptive implant, and that includes St John's wort, which is available over the counter. Now, the contraceptive implant doesn't protect against STIs, so again, just screening Jessica and reminding her about use of condoms as well. We can reassure Jessica that fertility returns rapidly on stopping the contraceptive implant, and routine review is in 3 years for a changeover. So Jessica starts the contraceptive implant and then comes back 2 months later. She tells you that she's been spotting daily for 4 out of the 8 weeks that she's had the implant. So I would refer you now to the bleeding card that I discussed earlier. And so what we need to do now is to have a look at excluding other causes of this bleeding. So have a think about maybe a pregnancy test, looking at doing STI screening if that hasn't been done already, and considering cervical dysplasia. Otherwise, we can then offer management of the bleeding. And so typically we might be using a combined pill, either cyclically or continuously, for around 3 months. But in Jessica's case, she actually has a contraindication to estrogen. So we might trial a 5-day course of mefenamic acid to see if we can settle the bleeding temporarily. And I'm going to pass over now to Janine.
Okay, thanks Suzanne. And I'm a gynaecologist, and so I often don't see a lot of these women straight up, and a lot of GPs and health nurses will be dealing with a lot of the common problems with regards to the pill, with regards to Implanon, and so I'm going to talk a bit more about specialist perspective with regards to contraception. So first up, IUDs for contraception are something that have
a lot of benefits, both with and without hormones, depending on the patient's selection. The Mirena with the progesterone has an added benefit of menstrual suppression, so has a great deal of use with menorrhagia, and I'll talk a bit more about that later on. And the copper IUD has the advantage of not containing any hormones, so it's the only long-acting reversible contraception that's available to women who are not able to use hormonal contraception. There are actually very few exclusion criteria to IUD use, as Kathy and Suzanne have gone through. So nulliparity is not one, adolescence is not one, someone who's not in a stable relationship per se is not a contraindication in itself. So with regards to using IUDs in nulliparous women, there have been studies looking at the effectiveness of the device, but then also with any difficulties as far as insertion and continuation. And so a large study that was published this year in the Journal of Family Planning showed that at 12 months there was a continuation rate of 89% in nulliparous women who were using IUDs, but 75% of those women were reporting that the insertion went very well, and more than 95% had a successful insertion with the first attempt. So there were no increase in complications, including pain. There was no increase in expulsion rates with nulliparous women. There was no increase in infection rates or perforation rates. Interestingly, the only women who are reporting an increased pain are women with the copper IUD rather than the Mirena, and certainly that's seen with both parous and nulliparous women, that there can be increased cramping as well as increase in the flow of the menstruation. So the majority of insertions are able to be done in an outpatient setting with little or no local anaesthesia, so not all IUDs need to be referred to a gynaecologist, and certainly so long as staff are adequately trained and work in a setup where there's appropriate support, that the insertions can take place within primary care. So you require experienced staff who are trained in insertion, so that can be gynaecologist, GP or a nurse. You need an assistant to help with the insertion, and there's a poll that's just popped up now. So a 48-year-old woman who's reached menopause should be advised to continue contraception for 2 years after her final period. True or false? So wait for that to come in. So I think we've probably got the answers in now. If we want to come up with the answer. Or do I tell you the answer? Do we stop the poll now? And as far as the answer would be that yes, she should continue for at least 1 year past her last menstrual period, or until the age of between 51 and 55, depending on the woman's situation. So back to the insertion information. So you need to have a clinic that has appropriate setup, has appropriate time allocated for an insertion, including the management of potential insertion-related reactions, which can be unpredictable. So
So someone who has a vasovagal reaction, you need to have the ability to manage that appropriately. And just in this month's Australia-New Zealand Journal of ONG, there's actually an article from the Family Planning Association in New South Wales that has been training registered nurses to insert IUDs. And they have had very favourable results, with 91% of insertions were successful without any doctor assistance, and there was actually no difference between nulliparous and parous women as to predicting when insertions were not difficult. So just a picture of a small setup in the corner, but with the insertions of IUDs in primary care. So there's not many GP practices who insert IUDs, but there has been an increased interest recently. And as I said, you need the prioritisation of clinic time and staff. And you also need champions in primary care who are willing to be able to be trained and set up to provide this sort of service within the community. So there is training available through family planning or your state equivalent, and there's information on the website with regarding this. The Royal Women's Hospital in Melbourne does have training places through their Choices Clinic, but these are limited, and the priority is given to those who are ready to use the technique in practice. It's best to have clinical-based sessions so that you're getting practical hands-on experience. So with regards to the copper IUD, there certainly record that heavy bleeding will be more common with the use of this IUD. It is a predictable adverse outcome due to the mode of action with the foreign body and the copper causing some inflammation within the endometrium. So counselling the woman to expect this is very helpful. And then to give her a script for some tranexamic acid and also prophylactic non-steroidal and anti-inflammatories to be used with each period for 5 days at 3 times a day can be very helpful with managing the bleeding and also some cramping. It will often settle with some time, but then with the implant, sometimes with the Mirena, troublesome spotting and light bleeding, the use of the combined pill for a short time can be beneficial, but with the copper IUD, this can be less predictably helpful. So mainly that they've been counselled that they may expect it, that they can use simple medical treatments to help manage it. If it's a single episode or distant from the time of insertion, to always consider expulsion or pregnancy, so to check for the strings, and if you can't see the strings, to organise an ultrasound, but also to get a pregnancy test. So the things not to miss with IUDs, so if there is a lost string, then it's important to check whether or not it's there, whether or not it's been expelled or perforated the uterus. So especially if there's been a concern about it being placed at the time of a surgical abortion, and that there is any concern of a higher risk of perforation, such as with lactation mentioned earlier. So important to check for the strings. If they're not there, as I said, to do a scan, do a pregnancy test. If the Mirena's been in place for a few years, the strings have been previously noted, the patient's amenorrheic and hasn't had any change in her menstrual pattern, then it's most likely that the strings have just been drawn up into the cervical canal, but it is quite easy to organise an ultrasound scan if you're concerned, and obviously a urinary pregnancy test. So with regards to pain and IUDs, the things to consider are the timing from the insertion. So certainly it can be in the weeks following the insertion, sometimes a week or two for the IUD to settle in from a cramping point of view, and using anti-inflammatories during this time can be very beneficial.
and also to consider the reason for insertion. So a lot of women, especially with the use more of Mirena around menorrhagia and around pain, have pain initially, and that it may be that there's a percentage of those women who actually experience more pain with an IUD, and that can be for several reasons, but it may be the underlying cause for their pain in the first place with regards to sensitivity within the uterus. So also to question whether it is possible that it could be misplaced. There's a possibility of infection, but overall that is very low, and it's important to consider the other causes as well. So a speculum examination will indicate whether the strings are there and also whether there's partial expulsion. So if you can see the stem of the IUD at all, then you remove the IUD. If there's obvious signs of infection, such as a purulent discharge, then you're able to take swabs, and depending on the degree of infection, which I'll discuss in a minute, or the degree of discharge, will dictate whether or not you should remove the IUD. The ultrasound will help to exclude perforation or malposition. Sometimes IUDs are reported as low-lying within the uterus, and if a woman is experiencing pain that's not settling, bleeding that's not settling, or has settled and starts to return, and an IUD is reported as low within the uterus, especially with a Mirena, I'd often look at replacing that to see whether one that was correctly positioned would be more effective. So with regards to infection, that not all discharge is infection. So certainly there can be some ongoing discharge with a Mirena that can be a brownish sort of discharge because of persistent minimal blood loss. So it's very important to have accurate diagnosis, because an ascending infection is very uncommon. It's increased slightly within the first 3 weeks after an insertion, but still very low. And then after that, because of the thickened cervical mucus from the progesterone effect, it's very uncommon to have an ascending infection. So before you take it out, clinically assess what's happening, but also appropriate swabs and tests such as for chlamydia, PCR, a mycoplasma, and bacterial vaginosis swabs. Swabs for gonococcus in high-risk populations, but overall the infection rates are very low. And I think I've just lost one, no. So if there is a degree of cervicitis or bacterial vaginosis, it's fine to treat this with the IUD in situ. If it does look like there is an ascending infection or the infection is not responding to treatment, then you need to remove the IUD. And the guidelines for antibiotic treatment do change, so it's important to consult therapeutic guidelines, but using azithromycin 1 gram stat and repeat in a week, or doxycycline 100 milligrams twice a day for 2 weeks, plus metronidazole 400 milligrams twice a day for 2 weeks, and then adding in amoxicillin clavulanic acid if it's not an STI-related infection. If a woman has had a past history of treated PID, it's not a contraindication to an IUD, only a contraindication to insert an IUD if there is active infection present. The other thing to clarify that Kathy had mentioned earlier with regards to ectopic pregnancy, if a woman has had a previous ectopic pregnancy, that's not an exclusion criteria for her having an IUD. And an IUD in situ, that overall the pregnancy rates are extremely low, so ectopic pregnancy rates are extremely low, But if a woman does have a pregnancy with an IUD in situ, then it is more likely to be ectopic. Another common misunderstanding is about IUDs being removed at the menopause, or how to time menopause with the amenorrhea that is common with the Mirena. So there's no problem with leaving an IUD in for longer than 5 years if it is after 50, because contraceptive effect is tailing off rather than ceasing abruptly, and that as well as the contraceptive benefits, that there's also benefits with regards to menstrual loss. So a discussion needs to be had at around 50 years of age if a Mirena is still in place, and that it is at around the 5-year stage of use, that the chance of a pregnancy in that situation is extremely low. But if the woman is not sure that she is wanting to rely on that alone, then the combination could be with a barrier method, perhaps changing the IUD, or to look at supplanting with you could use an oral progesterone, or an implant would be another option. So you'd usually recommend that the Mirena comes out within the first few years of being 50, but it doesn't have to be right at that 5-year mark. And certainly it also offers a progesterone component with HRT. So this is not how you manage heavy menstrual bleeding with a Mirena, but hormonal contraception can have a lot of benefit as regarding management of heavy menstrual bleeding at the same time. So increased bleeding can be structural or functional. So with regards structural, within the uterus itself, so important to exclude pregnancy, think about whether there is an IUD in place, whether there could be something within the endometrium such as a polyp, whether there could be any endometrial hyperplasia or risk of cancer. A very quick aside about the reporting of endometrial hyperplasia on ultrasound. It's important to remember that this is a pathological diagnosis, not an ultrasound diagnosis, and that it can be suggested that there is a thickened endometrium, that there is an unusual appearance to the endometrium, but that this is not something that is has a high correlation with hyperplasia. The other thing as an aside is that obtaining an endometrial thickness for a premenopausal woman has limited use as to an upper limit as a cut-off measurement, which is not the same as in post-menopausal women. So we often, as gynecologists, will see women who have been referred in because of a reported thickening of an endometrium, but it's difficult to interpret this if they've still got menstrual cycles. With regards to fibroids, they work partly by increasing the endometrial surface area to increase bleeding, but they can also have defects within their local hemostasis. So they can cause increased bleeding, especially if they're situated near or adjacent to the endometrium, or that they're significantly expanding the endometrial surface area. But otherwise, they're very common, so up to 70% of women, depending on age and population, will have fibroids. They're most often asymptomatic and coexistent with the pathology and any underlying pathology for heavy bleeding. So functional bleeding, which can be anovulatory or ovulatory. So ovulatory bleeding, that they have still very regular heavy periods with a loss of local endometrial hemostasis, whereas anovulatory is systemic in nature, so there's a disturbance of the HPO axis and disturbance with regards to the control of the endometrial growth and shedding. There's also some degree of deficiencies within the local hemostatic mechanisms. It's important to remember bleeding disorders, so up to 10% of women, or just over 10% of women with von Willebrand's disease will actually present with menorrhagia as their only problem. So these women would often have lifelong menorrhagia, but it's important to remember that in your testing. So clinical evaluation, if you've got a woman with abnormal bleeding, to examine her, to remember to think about pap smears up to date, whether it could be infection, to check an ultrasound to look for any intrauterine pathology, to check a full blood examination. If she's got regular heavy bleeding with a normal ultrasound, a normal pap, a normal FBE, then certainly a trial of tranexamic acid and non-steroidals, especially if pain, but to consider the combined oral contraceptive pill depending on the neck. If she's got very irregular heavy bleeding, then you need to start thinking about further testing to look at her gonadotropins, the thyroid function, and prolactin, to look at her androgens and the sex hormone binding globulin, which can indicate possible polycystic ovarian syndrome, and I'll talk about this shortly. And then if they've got abnormal bleeding, such as postcoital bleeding, intermenstrual bleeding, postmenopausal bleeding, pap smear abnormalities, or abnormalities on an ultrasound that you're not sure about how to interpret, then to refer to a specialist. So as far as treatment options, so hormonal contraceptive treatment options that also address heavy menstrual bleeding, local progestins, Mirena IUD, so this is the 20 microgram levonorgestrel, which is released daily for 5 years. So this has the greatest impact on bleeding volume of any medical treatment that we have up our sleeves. So 94% decreased blood volume with each period at the 3-month mark, and 76% of women wanted to continue using the Mirena beyond the 3-month mark. So when women have been interviewed comparing the use of the Mirena, comparing it with an endometrial ablation, that it shows similar results as far as a decrease in overall menstrual loss at 12 months and also equivalent satisfaction between the two groups. And there was a very large trial in Scandinavia with women with ovulatory dysfunctional uterine bleeding who were scheduled to have a hysterectomy, and with use of the Mirena for up to 12 months, I think it was, that 64% elected to cancel their operation compared to the 14% who were just allocated to medical treatment. So extremely effective, and then has the advantage of extremely effective contraception that's long-acting, low side effects, and that it does not suppress estradiol levels. So it does not have the decrease in bone density, and so long-term use with back-to-back Mirenas is not a problem. It doesn't always stop ovulation. So with regards to the estradiol levels, even if the woman is not ovulating with the Mirena, that her estradiol levels are still within the normal luteal, normal follicular levels, and the suppression of ovulation is not the main way that it works with regards to contraceptive efficacy. Implantable progestin, so the Implanon, which lasts for 3 years, as Suzanne and Cassie have both gone through, so very effective. The bleeding pattern is a little more variable than with the Mirena. There's some numbers there comparing it with Depo, but overall much lighter bleeding, but the troublesome infrequent bleeding can be a bit more common. But usually within a few months you know what the pattern will be, but it can take up to 12 months to stabilise. Using the oral contraceptive pill as a combined estrogen progesterone is very effective management of both anovulatory and ovulatory menorrhagia, but there are few available data to support looking at head-to-head comparisons. So using combined estrogen progesterone in one randomised trial showed a 50% reduction in menstrual flow.
Another trial, which was comparing a triphasic pill and a placebo, showed that 50% of anovulatory dysfunctional bleeding was much improved with better life table scores. The Nuva ring is also something that probably is under-prescribed as far as effectiveness with menstrual control and also low side effects. Fibroids are very common, as I said earlier on, that they can affect bleeding but often not. They will decrease at menopause or in a hypoestrogenic state, but they can fluctuate in size, especially around the menopause. The malignancy risk is very small. And as far as other effects that they can have an effect on fertility if they're very large or impinging on the tubes, or if they're submucous. They can have pressure effects if very large, but if they're small and asymptomatic, then they don't need any other treatment. And there's no evidence that contraception that contains less than or equal to 50 micrograms of estrogen will cause growth of fibroids. So they do not change the criteria as far as prescribing separate to the NEC criteria. Long-term use of the Depo-Provera may cause fibroid shrinkage because of the hypoestrogenic state, but this will, as soon as you stop using it, they will increase in size again. If the cavity is markedly distorted, then IUDs are less effective. They're more commonly expelled. So it's still possible, but it would be a situation to refer for specialist management. So just moving through to endometriosis. So medical management, certainly endometriosis is very common. Somewhere between 10 and 15% of women during their reproductive lives. So it's a real bag of symptoms. So consider it in women who have cyclical and or non-cyclical symptoms such as dysmenorrhea, pelvic pain, dyspareunia, dysuria, dyschezia, infertility, fatigue, and the list does go on. Examination may reveal some tenderness in the pouch of Douglas or an adnexal mass, but often nothing. A good quality transvaginal scan can be very useful, but this is a highly operator dependent one. So if you're not sure, then referring to a tertiary level scanner can be very useful. Using CT, MRI or CA125 measurements are really helpful as far as the diagnosis. With the management guidelines, ESHRE is the European Society of Human Reproductive and Embryology, but their guidelines are quite available on the internet and quite straightforward. But basically, it's very reasonable to use empiric medical therapy prior to laparoscopy in appropriately selected women. So the majority of women with pelvic pain and possible endometriosis will report some improvement in their symptoms, up to 90% using empiric medical therapy. And this can be non-steroidal anti-inflammatories and or hormonal treatment. So both appropriate management to reduce endometriosis-related pain and primary dysmenorrhea. But the choice of hormonal treatment will depend on cost, on efficacy, side effects and the need for contraception. So it's important to discuss the management options with your patients as to where they are with things, with their fertility and also their current situation with regards to lifestyle, with regards to finance. So hormonal contraceptive therapy can be either progestogen only or combined estrogen and progestogen. So this helps to reduce the activity of endometriosis. It reduces the activity within the glands and reduces the inflammation with each menstrual cycle. So it doesn't just cover up symptoms, but it also helps to treat the underlying disease process. But if there are established endometriomas or established adhesions, then medical therapy won't help with this, and medical therapy won't help fertility. So depending on the woman's situation and the response to medical therapy is the step to consider. Surgery, certainly surgery is associated with a reduction in pain.
that symptom recurrence is common, so reoperation rates increase with time, so about 20% at 2 years, up to 50% at 5 years. But this duration of pain relief and a delay in disease recurrence is definitely shown to be with extended hormonal treatment post-operatively. So for at least a year, using something in terms of oral or contraceptive or using a LARC will improve the outcome with endometriosis. Polycystic ovarian syndrome, also very common, 12 to 18% of women in their reproductive years. Something to consider if there's menstrual irregularity, if a woman is overweight, has problems with hirsutism, has problems with fertility issues. So the diagnostic criteria, so 2 out of 3 of these criteria are required for the diagnosis. So oligo or anovulation, clinical and or biochemical hyperandrogenism, or polycystic appearing ovaries on ultrasound. So not just the ultrasound features to make the diagnosis. It's important to ascertain the current desire for fertility. So if a woman is overweight, to pursue weight loss, as this will often improve her ovulation, but also to assess the ovulation, to remember to assess the partner factors and to refer to a specialist as required. If she's wanting contraception, then to assess the MEC with regards to contraindications with hormonal methods, as you would do with anybody, but often these women have higher rates of obesity, hyperlipidemia, hypertension, and also to consider if they're smoking. LARCs have advantages of high efficacy, but no weight gain, a rapid return to fertility if that's desired, and you can also be using any of those if estrogen is contraindicated. If there is chronic anovulation, then there is an increased risk of endometrial hyperplasia or cancer, and the progestogen will improve the rates of this, so will provide endometrial protection. They can also have anti-androgenic effects, so the progesterones with cyproterone acetate, drospirenone, can improve the androgenic effects with PCOS, and estrogen will provide cycle control as well as increasing their sex hormone binding globulin, which will subsequently decrease circulating androgens. And you can use this combined estrogen-progesterone pill as a continuous regime, not just a cyclical regime. So with regards to when to refer to a specialist, if there are IUD issues that are of concern, so if there's perceived difficulties with insertion, if the woman's had previous expulsion or malposition problems, or if there's suspected uterine cavity distortion, if there's difficulties with finding suitable contraception, if there's ongoing bleeding issues, if there's trouble with pain, with infection, or there's a need to evaluate the uterine cavity better than a transvaginal scan, or if there's coexisting or significant likely gynecological or medical issues, then to refer on to a specialist. So I'm going to pass over to Suzanne and Kathy for frequently asked questions, but we've got another pop-up poll in the meantime. Does a perimenopausal woman need to use contraception? Yes, no, maybe, or don't know.
Thanks, Janine. Well, it looks like we've got a fairly conclusive answer there of yes, which is great. Okay, so I'm just going to go through some frequently asked questions. These are mostly questions that came through before the event. So what contraceptive advice can I provide for a woman over 50 years of age? Well, the first thing with that is natural conception is very uncommon over 50 years of age, but it does happen, and it might be particularly important for that woman that she doesn't actually conceive. I always think it's a good way of getting into the Women's Weekly or something if you have a natural conception over 50. Generally, we say that the combined hormonal methods, like the pill and the vaginal ring, should be stopped at 50. Probably the guidelines are softening a little bit at that, but at the moment that's our current advice, and depo should generally be stopped at 50. as you age, your risk of cardiovascular disease, heart attacks, strokes, and venous disease increase. So in terms of the combined pill, that's the reason. And with Depo, it's really just the arterial disease. The other thing is with Depo, it drops the estrogen level. Estrogen's thought to be cardioprotective, so theoretically, no evidence for this, that the women might be at high risk of cardiovascular disease. You also have the concern about bone density with Depo. Theoretical, again, we don't know of any long-term ill effects. FSH measurements aren't useful with combined hormonal methods because it's suppressed. However, they can actually be used using progestin-only methods, and bleeding methods are unhelpful when a woman's using exogenous hormones. So I've just got a little bit of a table here. So you've got a 50-year-old woman needing contraception. If she's on combined hormonal or Depo, she can switch to a barrier method. If she's using Depo, she really needs to be amenorrheic for 2 years because she can have quite a long period of amenorrhea after Depo, but then actually ovulate again at a later stage. Or if she's on a combined hormonal method, if she's amenorrheic for a year, she can actually stop using the method. So obviously if she's on a non-hormonal method like condoms or a copper IUD, she can stop after 1 year of no period. Alternatively, you could switch to a progestin-only pill, implant or IUD. Quite a few years ago, I would have sort of thought it was almost ridiculous to put in an IUD in a 50-year-old because it would have such a short time span. But I'm seeing a little bit more often at the moment, and it is a very effective method. There are a few side effects, and there can be quite a big advantage with Mirena in terms of bleeding. So if she's switching to one of those methods already on that method, you could just continue until she's 55, especially if it's a hormonal IUD. Sometimes you take the hormonal IUD out, but the woman is actually not in need of contraception, but there may be still some bleeding left. So we always tend to err on the side of leaving it in. If she's amenorrheic, you could check her FSH, and if it's over 30, twice, at least 6 weeks apart, you still need to wait another year, but then you could stop the method at that stage. Another question we got is, are contraceptives effective for obese women? And essentially the answer is yes. There's really no evidence of decreased efficacy. There is evidence of decreased circulating hormone levels, particularly that there's some evidence in relation to the contraceptive implant, but there's no clinical or physiological evidence that BMI affects efficacy of hormonal methods of contraception. So occasionally you hear people say that obese women need a higher dose of the pill, that there's no evidence for that. Progestin-only pill, our own handbook used to have a recommendation about that, but it's been changed, and we don't have a recommendation to double the dose of the mini pill in larger women. The contraceptive implant product information suggests that the implant could be changed at the 2-year mark rather than the 3-year mark for heavier women. It doesn't actually define heavier women. Very few failures with implant-on anyway, and heavier women aren't overrepresented in the failures. So we'd see no reason to remove it other than at the scheduled time. So do they cause weight gain? And I think Janine's really covered this. There's basically no evidence for combined methods, the implant or hormonal IUD. However, with Depo, there seem to be about 20 to 25% of women gain about 10% of their body weight within a year. If they start gaining at the start, they're likely to continue to gain. The other, 75 to 80% of people just gain weight as everyone normally does with age. Sometimes that can be a little bit of a hard sell to people, particularly a young woman if she's thinking that she's got a 1 in 4, 1 in 5 chance of gaining, maybe 5, 6, 7 kilos. Common question we get is, how do you manage breakthrough bleeding for women on the combined pill? And unfortunately, I haven't got really good answers for this because the evidence is quite limited. There aren't really the head-to-head trials between pills to actually say one is better than the other, except the vaginal ring has gone head-to-head with 2 different pills, and it was superior to both of them in terms of breakthrough bleeding. So I suppose the first thing to think about is another cause, particularly if it's a young woman, whether it's a chlamydia infection. Pregnancy is always important to think about and possibly exclude. You might want to know what the type of bleeding is, for example, if it's post-coital or it's truly just intramenstrual bleeding. So if the vaginal, basically the concept is the lower dose of the estrogen, the high chance of breakthrough bleeding. So you can increase the dose of estrogen. However, we generally don't recommend a 50 microgram ethanol estradiol pill because there's a high risk of arterial disease or venous disease. We would actually suggest just trying another pill. This is completely anecdotal, but we actually often find that Brevinor 1 is quite good for breakthrough bleeding. But you can just try another pill and see how they react to it. I tend to find that once you've tried a couple of pills, say the vaginal ring, there's no point sort of just going on and just trying all the different pills. Something has probably just changed in the way the endometrium responds to the hormones in the contraceptive. It'll still be effective as a contraceptive, but it just comes to a stage where it's unlikely that they're going to have any further benefit by changing, and you might think of another method, perhaps like a hormonal IUD. They're not getting much of it, and they're prepared to put up with it, and they're young. You might even consider an ultrasound, and if all's fine, they can just continue on. How long can the pill be used continuously? Basically, we've got no upper limit to that. The trials have been up to 12 months, but there's no sort of logical reason to restrict it beyond 12 months. With the combined pill, you just run it without a placebo break. With the vaginal ring, we say a new ring every 3 to 4 weeks. Obviously, 4 weeks is going to be cheaper than 3 weeks. Theoretically, it's more effective because the pill, the vulnerability of the pill in terms of efficacy is around the placebo breaks because the body starts kicking in, you may get close to ovulation, and if you miss pills around that break, that's when you're most likely to have a failure. So not having that pill-free break would theoretically improve that. There is a pill available as an electronic dispenser called Yaz, and it will allow women to take a 4-day break when bleeding occurs, and that's been shown to be quite acceptable to women. It actually becomes with a very annoying noise that goes off when it's time to take your pill. They've trialled using it with the noise and without the noise, and the noise is much more effective at making you actually take the pill. There are pills containing 365 active tablets available in other countries, but not in Australia. So are there any new contraceptives available? Unfortunately, we're very excited about having a low-dose hormonal IUD in Australia, an alternative to Mirena, but unfortunately it's not likely to be available in the near future. We did get a very good question about anything new in the pipeline for men. Unfortunately, hormonal methods of contraception have proven to be effective and acceptable to men. There are some difficulties in that it can take 3, 4, 6 months to suppress spermatogenesis. Some men don't get complete suppression and then obviously take that time to recover. But unfortunately, there's been no commercial interest in it, and it's very unlikely that we're going to get a male hormonal method in the near future. A number of things looking at more immediate things like stopping the transport of sperm or splitting sperm, but nothing near. We do have a new diaphragm. The old diaphragm will be going off the market soon, and probably in a lot of places it's no longer available. There were 4 sizes of the diaphragm. Now we have a Kaya, which is a one size fits most women. The women can buy it from the chemist, but without a prescription, but it's recommended that a health professional checks the fit. So basically you would get the woman to come in with the Kaya in place, and you need to check that it actually covers the cervix properly and that it's not very loose and floating around. We are actually most likely going to get a new contraceptive in Australia, an emergency contraception called Ulipristal. Some of you who've trained overseas will be familiar with this. It's been available in the UK since about 2009. It's what's called a selective progesterone receptor modulator, similar to RU486 or mifepristone, which is used for emergency contraception in some countries. The main action is to delay ovulation, so the sperm just basically dies waiting. With ovulation, with the levonorgestrel method of emergency contraception that we have at the moment, once the woman started the LH surge prior to ovulation, it basically has almost no effect. But with ulipristal, there is an effect even after the LH surge has started. And it's got a higher efficacy than the levonorgestrel method, like Postinor that you can buy over the counter. And that's particularly so in the 72 to 120 hours after it's taken. With the levonorgestrel emergency contraception single dose, there's good efficacy proven up to 96 hours, but although our guidelines allow it to be used up to 120 hours, there's little or any evidence of much efficacy in that time, but it might be worth trying. The downside is that it will be an S4, available only by prescription, just to start with anyway, and it's going to be more expensive than levonorgestrel emergency contraception. Some of you might be familiar, a few years ago there was a concern about BMI and whether levonorgestrel emergency contraception would be effective for women at higher BMIs. That information is actually quite uncertain. However, in the study that did explore this, there was less effect of increasing BMI on ulipristal efficacy. There's a couple of problems with it too, though. Our practice at family planning, if someone was starting on having levonorgestrel emergency contraception, would be to start them on a hormonal method of contraception immediately, or quick start. You obviously can't exclude pregnancy in that situation, and emergency contraception does fail. But a number of studies have shown that you'll have far fewer unplanned pregnancies if you actually start the woman on the day that you see them. So it's the perfect time. Unfortunately, there's a concern with this method that initiating the emergency, hormonal method might actually decrease the efficacy of the ulipristal. So it's actually recommended to wait 5 days to initiate. So it can be a difficult decision weighing up whether someone's at more at risk by having a slightly less efficacious method of emergency contraception, or more at risk of waiting 5 days to start their method of contraception, and of course the very high risk that they don't actually come back if it's something like an implant. It's not recommended if they're on liver enzyme inducers, whereas with levonorgestrel we can actually increase the dose, and copper IUDs, which are an extremely effective form of emergency contraception, aren't actually affected by liver enzyme inducers, and it's also not recommended if they're on proton pump inhibitors. With lactation, the current advice is to discard milk for 1 week. With levonorgestrel, the current product information suggests that you should discard milk for 72 hours, but our recommendation is that women just breastfeed normally. There's limited data regarding exposure if it does actually fail and the woman is pregnant and she doesn't want to continue, but we would actually feel it's not a medical indication for a termination if that were to occur. It's not recommended for use more than once a cycle, whereas levonorgestrel you can use as many times as you like per cycle, and it's certainly not recommended if more than 120 hours has passed since the unprotected sex. So just some resources. So we've got the family planning resources that Suzanne has mentioned before. You can actually download those from the website. The medical eligibility criteria for contraception use, I'd really strongly recommend downloading those. Although I work in contraception all the time, I find I frequently refer to them. The WHO medical eligibility criteria, very similar to the UK, but have been updated more recently. But as I mentioned, the UK are planning to release their update in late April this year. Family Planning Victoria and the Women's Hospital have a number of information sheets on contraception. I just want to give a little plug for a study that Family Planning New South Wales is involved in. They're recruiting doctors, prescribing Zoli, and if you don't prescribe Zoli, if you're in an area where it's too expensive, it's also prescribers of 30 microgram ethanol estradiol and levonorgestrel contraception as a comparator. They're looking at the risk of VTE. It's hoped with the newer pills like Zoli and Clara that they may not have as high a risk of DVT as the pills that we have at the moment. And I think we've basically come to the end. So we'll finish there. Thank you.
Thanks, Kathy. I'm sorry, but we actually don't have any more time for questions. I know there have been questions that have come in, and what we'll try and do is we'll answer those. And the webinar will be held in the Jean Hales webinar library, probably from Friday. Everyone who's registered will be sent a link so that you can watch it again or cut to the areas you want to revisit. And some of those some of the questions, that have been sent in, we will try and answer, and we'll have that up in the same area in the webinar library. So I'd like to thank our fantastic panel tonight. We had some technical issues at this end. Hopefully that wasn't necessarily evident to you watching out there. I'd like to say a big thank you to Family Planning Victoria, who's partnered with us tonight and provided two of our fantastic speakers, and thanks to Janine Manwaring too. I think only one person had done a webinar before, and I think they've done a great job tonight. So don't forget, you will be linked to the evaluation. You need to fill out that evaluation in order to get your CPD points and to receive a certificate, and to give us any feedback. We'd love to hear from you. We'd love you to tell us what you'd like to hear next. Just someone did ask about IUD training, and Family Planning Vic, I know, offer that. And I'm sure if you check out the family planning organisation in your state, you'll find more than likely that you'll be able to do IUD training in your area. So please go to your state-based organisation for that. So thank you very much. We'll be back in May for our next webinar, and I hope you'll join us then, and I hope you've enjoyed tonight. Thanks very much.
Thank you, Louise, Kathy, Suzanne, and Janine for your presentation, and thank you to everyone for attending today's webinar. Please stay logged in to take our online survey, which you'll be redirected to now.